Hello everyone, this is Dr. Frances Munroe, and I'm here today to discuss the topic of enuresis. This presentation has been written to help you raise awareness of the NICE clinical guideline on nocturnal enuresis. This guideline was written for healthcare professionals and other staff who care for children and young people with the problem of bedwetting. The term bedwetting is used in this guideline to describe the symptom of involuntary wetting that occurs during sleep without any inherent suggestion of frequency of bedwetting or any pathophysiology. Bedwetting is a widespread and very distressing problem that can have a deep impact on a young child or young person's behavior, their emotional well-being, and their social life. It can also be very stressful for parents and their caretakers. The causes of bedwetting are not yet fully understood. It can be considered a symptom that may result from a combination of different predisposing factors. There are a number of different disturbances of physiology that can be associated with the development of bedwetting, and these disturbances may be categorized as either sleep arousal problems, polyuria, and bladder dysfunction, and it may also run in families. Children and young people who have bedwetting may also have symptoms related to the urinary tract during the day. So a history of daytime urinary symptoms is also very important in determining the approach to the management of bedwetting. Next, we're going to take a look at the demographics. The prevalence of bedwetting actually decreases with age. Bedwetting less than 2 nights a week has a prevalence of about 21% at age 4.5 years old, 10 to 15% prevalence at age 7, and with each subsequent year, 15% of bedwetters become dry. By the time they reach adolescence, only about 1% of adolescents remain enuretic. Nocturnal enuresis usually affects boys more than girls. However, daytime wetting is more common in girls. Enuresis is also more frequent, occurring in lower socioeconomic populations and in much larger families. Genetics also plays a part in the development of enuresis. If both parents were bedwetters, there's greater than 77% chance that their offspring would have enuresis. If one parent was a bedwetter, greater than 45% chance. If neither parent suffered from bedwetting, there still is a 15% chance that the child may become enuretic. There is a concordance for enuresis, about 68% for identical twins versus 36% for fraternal twins. Parental age of resolution is also important as a predictor of when the child's enuresis may resolve. The NICE guideline makes several recommendations on the assessment and management of bedwetting in children, and this applies to children and young people up to 19 years of age with the symptom of bedwetting. Groups that are covered, there's no minimum age limit for inclusion, and even children with special needs who continue to have nighttime bedwetting or with or without daytime urinary symptoms are included. Some groups that are not covered would be adults aged 19 years or over with any type of incontinence, and children and young people who have daytime urinary incontinence only. The NICE guideline contains over 99 recommendations about how care can be improved for enuresis, but the experts who wrote the guideline have chosen several key recommendations that they think will have the greatest impact on care. They are divided into 8 areas of key priority, and these are shown on the slide, and then there are a total of 10 recommendations. The key priority recommendations will be labeled as KPI throughout. They include principles of care, assessment, planning, advice on fluid intake, diet, and toileting patterns, different reward systems, initial treatment with alarms, initial treatment with medications, and the lack of response to initial treatment options. Principles of care include informing children and young people with bedwetting and their parents that it is not the child or young person's fault. Punitive measures should never be used in the management of bedwetting. Another principle of care is to offer tailored support, assessment, and treatment to all children and young people with this problem, and do not exclude the younger children, those under 7, from the management of bedwetting on the basis of age alone. In this presentation, I will start by providing some background information about the NICE guideline and why it is important. I will then talk about the key priorities for implementation. The NICE guideline contains 10 key priorities for implementation. Then I will summarize the costs and savings that are likely to occur when implementing the guideline. I will also discuss the assessment, diagnosis, and treatment strategies. And finally, the presentation will end with further information about the additional support provided by NICE. A thorough assessment should be done, including history taking, asking whether the bedwetting started in the last few days, weeks, or months. Is it possibly a presentation of another systemic illness? Ask if the child had been previously dry at night without assistance for 6 months. Inquire about any possible medical, emotional, or physical triggers, and whether treatment is needed for those triggers. Ask about any patterns of bedwetting, including how many nights a week does it occur, how many times a night does bedwetting occur, and is there a large or small amount of urine? Does the child or young person wake up after the bedwetting? Are there any daytime symptoms? Ask about daytime toileting patterns, including whether symptoms occur only in certain situations, avoidance of toilets, for example at school, or any other settings. Ask specifically about a young person's fluid intake throughout the day and whether they are restricting fluids at night. Check into other comorbidities that could be associated with bedwetting. Also discuss in detail with the parents and caretakers whether they need any additional support, if they are having difficulty coping with the burden of bedwetting, or if they are expressing anger or negativity towards the young child or person. Consider assessment, investigation, and/or referral when bedwetting is associated with severe daytime symptoms, a history of recurrent UTI, any known or suspected physical or neurological problems, or any thoughts of abuse. A detailed physical exam is important. Although most children will have a completely normal exam, it is important to look at the genitalia, inspecting the ureter, looking for any labial adhesions, any urethral abnormalities, or any trauma, checking the abdomen for distension, fecal impaction, looking at the upper airway for enlarged tonsils or adenoids, any signs that could indicate sleep apnea. A thorough neurological exam is also important, and direct observation of urinary stream that could suggest any abnormality. Diagnostic testing would include laboratory tests such as urinalysis to rule out diabetes, urine culture if screening is positive for UTI. Avoiding cystourethrogram and renal ultrasound is important if you're looking at any symptoms of recurrent UTI, neurogenic bladder. Sleep studies may also be considered to rule out sleep apnea. Planning and management would include a thorough explanation of the condition and all possible treatments with the child and their caregiver. Also clarifying what the child and young person hopes to achieve with treatment. Exploring the child or young person's views about their bedwetting, and considering whether or not it is appropriate to first offer the alarm or medication depending on the age of the child, the frequency of bedwetting, and the motivation and needs of the child and their family. It is important to give advice on fluid intake and toileting, address excessive or insufficient fluid intake or any abnormal toileting patterns before you start treatment for bedwetting. Adequate daily fluid intake is very important, especially with medication use. Please take a look at the chart by age, sex, and total drinks per day. It is also important to advise the child and their parents to avoid the consumption of any caffeine-based drinks, especially in young people with bedwetting. It is important that they eat a healthy diet. They do not need to restrict diet as a form of treatment for bedwetting. It's also important to explain that reward systems with positive rewards for agreed-upon behavior rather than dry nights should be used either alone in conjunction with other treatment. Inform the parents and children they should not use systems that penalize or remove previously gained rewards. And it is important to try a reward system first for the initial treatment of bedwetting in young children who do have some dry nights. For the initial treatment using alarms, it is important to offer it as the first-line treatment for children and young people whose bedwetting has not responded to advice on fluids and toileting, unless the alarm is inappropriate or undesirable. An alarm may be inappropriate when bedwetting is very infrequent, less than 1 to 2 wet beds per week, or if the parents or caretakers are having a difficult time coping with the burden of bedwetting, or if they're expressing any anger, negativity, or blame towards the child. Make sure to consider an alternative type of alarm, for example, a vibrating alarm for the treatment of bedwetting in children and young people with a hearing impairment. Some additional information and support is available. You would want to talk with children and their parents about the benefits of combining alarm treatment with a reward system and the high long-term success rate of alarm treatment, the different aims and goals of alarms, and the practical issues for using the alarms, such as the impact on interrupted sleep and the long-term commitment needed. The goal of alarm treatment is to train the child or young person to recognize the need to pass urine, to wake up to go to the toilet, or to hold on, learning over time to hold on or wake spontaneously and thereby stop wetting the bed. You would want to inform the child and the parents how to set and use the alarm, respond to it when it goes off, maintaining it, and dealing with any problems, who to contact when they no longer need it. Let the children and parents know it may take a few weeks for the early signs of a response to the alarm to occur. This would include smaller wet patches, waking up to the alarm, having the alarm go off later, fewer times per night, with fewer wet nights. Dry nights will be a late sign of response to the alarm, and this could take several weeks to achieve. The next slide shows some examples of different types of alarms that can easily be used to clip onto the child's pajamas. Next, we're going to talk about medication, the initial treatment using desmopressin, also known as DDAVP. This is often offered to children and young people over 7 years old if they want a rapid onset and/or short-term improvement in bedwetting. If the alarm is inappropriate or undesirable, DDAVP does come in both nasal pump and tablets, but the nasal spray is not recommended for treatment of enuresis because of reports of severe hyponatremia that have led to seizures and death. So we will only discuss the use of tablets for enuresis. The usual starting dosage is about 2 milligrams, which is 1 tablet. It can be increased 2 milligrams every 2 weeks for a maximum of 6 milligrams at bedtime. Children must limit their water intake to prevent the risk of hyponatremia. The duration of action of DDAVP is about 9 hours, so you may want to try to wake the kids who sleep longer than that to see if it helps. This medicine either works or it doesn't, and since it only controls one factor, the volume of nocturnal urine output. Other factors to consider do not exclude using DDAVP as an option for the management of bedwetting for kids who only have daytime symptoms. However, do not use it only for daytime wetting. It can be used in children with sickle cell disease as long as they can comply with nighttime fluid restriction. And it can be used with children with emotional, attention, or behavior or learning difficulties. There's no need to routinely measure children's weight, electrolytes, blood pressure, or serum osmolality. It's important to refer children and young people with bedwetting that has not responded to courses of treatment with either the alarm or DDAVP. They may need further review and assessment of other comorbidities that could be associated with a poor response. They may have overactive bladder, underlying disease, or other social or emotional factors. Another medication used is imipramine. The mechanism of action is the anticholinergic effect that increases the child's bladder capacity, and then the noradrenergic effect that decreases bladder detrusor excitability. Usual starting dosage is 25 milligrams 1 hour before bedtime, with a maximum 50 milligrams for 6 to 12-year-olds and 75 milligrams for greater than 12-year-olds. It has an efficacy rate of 10 to 60%, but the relapse rate off treatment is almost 90%. Some disadvantages include the low toxic therapeutic ratio. It is easy to overdose on imipramine, and it is the #1 fatal poisoning in Britain. Overdose signs would include ventricular tachycardia, coma, or seizures. Some mild side effects include anxiety, nervousness, constipation, dizziness, and dry mouth. It is relatively inexpensive, costing only $5 a month, compared to DDAVP, which is much more expensive. The NICE guidelines also talk about other recommendation areas, including lifting and waking, the anticholinergics, the tricyclics, and different training programs for the management of bedwetting. Some other key areas would include children under 5 years old with bedwetting. NICE has found that implementing this guideline is unlikely to result in any significant changes in resource use or cost, but there could be some savings depending on local circumstances. So offering the alarm as first-line treatment, using combination treatment with the alarm and medication when there's been no response, offering the medication alone, and the training of healthcare professionals, considering imipramine if there is no response to any of the other treatments. Some additional areas for discussion would be how can alarms be accessed for children who meet the criteria? How can we ensure that there are enough alarms available, that the service is well integrated, the team has a good awareness and understanding of the guidelines, who would be prescribing the medications, and how can we provide the information that is recommended for parents, caretakers, and children, including how to take the medication appropriately. Finally, if you'd like to find out more information, you can visit the NICE guideline website that is listed on the slide. You can download their quick reference guide, they also offer auditory support, baseline assessment tools, and additional guides for resources. I'd like to thank you today for your kind participation in this presentation.